All right, so let's talk about AV blocks before we get started. Really big thank you to everybody who's contributed to the page, everybody who signed up for the subscription, bought a t-shirt or a mug, or just sent a really nice comment. I truly do appreciate it. So thank you so much. Let's go ahead and get started with AV blocks. So AV blocks, they're super high yield. They always come up on exams. If you're going to get a dysrhythmia question, very good chance it'll be on AV blocks. So I wanted to dedicate a video going over all of the high yield info you need to know, as well as sharing some mnemonics for the topic. Before we begin, I want to go over some key concepts, some basic foundation you need to have an understanding of AV blocks. So let's first really quickly review the normal electrical conduction system of the heart, because like most things in medicine, identifying the abnormalities requires a solid understanding of what constitutes normal. So a normal electrical activity of the heart, it's like this long road. There's checkpoints along the road. The very beginning of this journey starts at the SA node, which is located in the right atrium. The SA node sends an electrical signal through the walls of the atrium, causing them to contract, and then it hits its first checkpoint on the road, the AV node. So the AV node is very important for today's topic, obviously. So the signal stops here really briefly to allow the ventricles time to fill, and then proceeds down into the lower chamber of the heart through the bundle of His. The signal travels down into the left and right bundle branches, which we can see here, and then finally into the Purkinje fibers down at the bottom of the heart here, which transmits electricity to the ventricles, causing them to contract. If you ever need a way to help remember this pathway, I have a mnemonic for you. Send a big bounding pulse. Send a big bounding pulse, SABBP, so that stands for S, SA node, A V node, B, bundle of His, the second B is bundle branches, and then the P stands for Purkinje fiber, so that helps you remember the pathway there. Now let's talk about a little bit about the ECG. So what you need to be familiar with for AV blocks. PR interval is really big. So the PR interval is the measurement of time it takes the electrical impulse to travel through the atria across the AV node to the ventricles. So part of that measurement includes that delay at the AV node, that first little checkpoint we discussed before. So on your ECG, your PR interval is a point measured from the beginning of the P wave to the beginning of the QRS complex. Now a normal PR interval is between 120 to 200 milliseconds. 200 milliseconds is 5 little boxes on ECG that we see here, or one large box. Anything longer than that, and we got an issue, likely an AV block, which we'll be talking about today. All right, so those are the basic concepts you need to understand before we get started. Now, AV blocks, they're broken down into a few subtypes we're going to go over today. You have your first AV block, which we'll start with our review today. You have your second degree AV block, which is further classified into a Mobitz type 1, which is also known as a Wenckebach. We have our Mobitz type 2, and then we have our third degree AV block. So let's break each of them down, talk a little bit about what you need to know about each. We'll start first with our first degree AV block. So this is a cardiac condition characterized by abnormally slow electrical conduction from the atrium to the ventricles. So a first degree AV block isn't really a block per se, as every impulse is still getting through to the ventricles, just getting there really slowly. It's taking its time. So it's more of a traffic type situation rather than the road being completely shut down in this case. So we have a slow conduction through the heart, most commonly occurring at the AV node, although it can affect the His-Purkinje system as well. So why is this happening? Let's talk about some of the etiologies next. So as far as etiologies, the first thing I want you to be aware of is this can be a normal finding, especially in athletes that have a slow resting heart rate. So those really well-trained athletes that have a heart rate of like 40 beats per minute, they can have a first degree AV block without any structural abnormalities of the heart. So a first degree block can be normal. What about the abnormal stuff? So in all types of AV blocks, medications can be to blame. There's a number of medications that can cause an AV block. Essentially, any drug that impairs or slows AV nodal conduction can cause a first degree heart block. The ones that you need to know, your AV nodal blocking drugs include digoxin, beta blockers, some calcium channel blockers, specifically your non-dihydropyridine agents like verapamil or diltiazem. They can all cause AV blocks. So on your exam, if they ask you what the underlying cause may be, make sure you're looking out for one of these meds. And if you need an easy way to remember the common AV nodal blocking drugs, you can remember the mnemonic A, B, C, D. So your main AV nodal blocking drugs start with A, B, C, or D. A standing for adenosine, B standing for beta blockers, C standing for calcium channel blockers, of course your non-dihydropyridine specifically, and then D, digoxin. So look for one of those meds. on the answer choices if they're asking you a med that could be causing the AV block. Another big one is myocarditis. This is another possible cause. And while there's many causes of myocarditis, viral illness, etc., for the exam, you absolutely have to remember Lyme disease. Lyme disease can lead to AV blocks, and the people who make exam questions, they just love to ask about this. So in patients with Lyme carditis, the degree of AV block can fluctuate quickly. It can start with a first degree AV block, quickly progress to a second degree or complete AV block. Main takeaway though, if there's a heart block in the question, make sure you're looking for Lyme disease in the answer choices. Next, myocardial infarction is another potential cause, often an inferior wall MI, as the AV node and inferior wall are both fed by the right coronary artery. There's, of course, plenty of other causes, infiltrated and dilated cardiomyopathies like sarcoidosis, certain muscular dystrophies, Lev disease. But for the exam, focus on your meds, beta blockers, calcium channel blockers, etc., Lyme disease, MI, and your normal variant, as those are the ones most likely to come up. All right, what about clinical manifestations next? So what you really need to know for clinical manifestations is asymptomatic or lack of clinical manifestations. Patients with first degree AV block are generally asymptomatic. It's not impossible to have some non-specific symptoms such as dizziness, fatigue, etc., but overall, most patients aren't going to have any symptoms at all. What about diagnosis next? This is probably the highest yield for all of these. Obviously, we're going to be diagnosing with an ECG. You diagnose with ECG. Now, what are you looking for on the ECG? Well, we know a first degree AV block is caused by a delayed conduction from the atria to the ventricles. So knowing that, where on the ECG can we look to calculate this delay? Well, as we discussed before, you determine that delay by looking at the PR interval, which measures the time it takes the electrical impulse to travel through the atria across the AV node to the ventricles. And as we know, the normal amount of time for this to take place should be a max of 200 milliseconds, one large box. Well, in a first degree AV block, there's a traffic jam, and while the signal is still getting through the ventricles, it's taking a lot longer than it's supposed to, and this leads to a prolonged PR interval, specifically a PR interval over 200 milliseconds. That's all you need to know for a first degree block. PR interval over 200 milliseconds, more than one big box. Nice and simple. And the key, which will be different than all of the other AV blocks that we'll talk about today, is the conducted impulse will always get through to the ventricles. All of that electricity, it's still getting through. There's always going to be a QRS complex. It's just taking longer to get there. So again, ECG diagnosis is made with a PR interval over 200 milliseconds. That's all you need to know. So there's a lot of mnemonics for heart blocks, a lot of ways to remember these. And for a first degree block, you remember the ECG findings by remembering the rhyme. If the R is far from the P, then you have a first degree. If the R is far from the P, then you have a first degree. That widened PR interval over 200 milliseconds. That's what you need to remember for your ECG findings. Let's talk about treatment next. So we do an ECG, we see the patient has a first degree block. How do we treat this? Do we even need to treat this? Most of the time the answer is no, but it depends on a couple of different factors, mainly related to whether or not these patients are symptomatic. And treatment for a first degree block, it's pretty simple. It's basically two options. You either do nothing or you give them a pacemaker. So if they're asymptomatic, you're just going to observe. You don't need to do any sort of treatment specifically. Obviously, if there's an underlying cause like a med that can be discontinued or another underlying treatable cause, that should be addressed. But otherwise, asymptomatic doesn't require any intervention. And then there's some rare cases that will get a pacemaker. So with patients that have a wide QRS complex in conjunction with a prolongation of the PR interval, patients with something known as pseudo pacemaker syndrome, nothing that you need to memorize for the exam. Just remember, most patients with a first degree AV block, just observe pacemaker in some rare cases. All right, so quick recap of a first degree heart block. This is a cardiac condition characterized by slow conduction from the atrium to the ventricles. All beats are still getting through. They're just taking their damn time. It can be a normal finding, especially in a well-trained athlete with a slow heart rate. Most patients are going to be asymptomatic. You diagnose with an ECG, PR interval over 200 milliseconds, and most of the time you're just going to observe pacemaker only in rare cases. That's a first degree heart block. Moving on to our second degree heart blocks. Remember, this is broken down into two subtypes, Mobitz type 1 and Mobitz type 2. Let's start with Mobitz type 1, aka Wenckebach, named after the Dutch physician Carl Friedrich Wenckebach. So this is a progressive lengthening of the PR interval, often due to impaired conduction within the AV node, resulting in occasional non-conducted impulses. So this is similar to a first-degree AV block where there is some traffic on the road to the ventricle, so we have this prolonged PR interval. The difference is in a Mobitz 1, the traffic keeps getting worse and worse, leading to the PR interval getting longer and longer until eventually everything just comes to a standstill, the road shuts down, the atrial impulses fail to reach the ventricles, and you have a dropped beat. So again, Mobitz type 1, aka Wenckebach, there's some traffic on the road, the traffic keeps getting worse and worse, PR interval getting longer and longer until all traffic comes to a stop and you have a non-conducted P wave, no QRS complex. It's important to know that a Mobitz 1 usually occurs within the AV node. This is important because even though all of the conditions we're going to go over today, they're all called AV blocks, they don't all occur within the AV node. For instance, Mobitz type 2, which we'll talk about next, almost always occurs from conduction system issues below the level of the AV node. And it's part of the reason why in a Mobitz 1, which affects the AV node, we see this progressive PR lengthening, and in a Mobitz 2, we do not. And we'll go over that in more detail when we talk about Mobitz 2 shortly. Let's talk about etiologies next. So as far as the causes, for the most part, the same as in a first-degree heart block with a little difference, which I'll talk about in a second. So once again, this can be a normal finding in patients like athletes with no underlying cardiac pathology. And actually in up to 10% of long-distance runners, 10% of long-distance runners have been found to have a Mobitz type 1 second-degree block, which I actually found pretty interesting. Moving on to your meds, of course, nothing different here. Your AV nodal blocking medications like we went over before, DIG, beta blockers, non-dihydropyridine calcium channel blockers, they can all cause a Mobitz 1, of course. Don't forget your myocarditis from Lyme disease, myocardial infarction, as well as other underlying heart diseases. And then hyperkalemia. This is the only one I didn't mention in a first-degree block, as this is more common in your second and third-degree blocks. There's, of course, many of other causes, iatrogenic causes like post-cardiac surgery, cardiomyopathy. But the main ones, the ones that you need to memorize, the ones that will likely come up on an exam question, the way that I used to remember them is with the mnemonic blocks, as in AV blocks, BLOCKS. The B stands for beta blockers, the L for Lyme disease, O for ordinary, as in your normal variant in young athletic patients, C, calcium channel blockers, non-dihydropyridine agents specifically, K for K increase, as in hyperkalemia. Remember the element symbol for potassium is K. And then finally, the S stands for STEMI, as in ST elevation MI, to help you remember your myocardial infarction. So again, remember, blocks stands for beta blockers, Lyme disease, ordinary, calcium channel blockers, K increase, and STEMI. Moving on to clinical manifestations next. Most patients, just like in a first-degree block, they're going to be asymptomatic. Second-degree AV block rarely produces symptoms. Now, with that being said, if the sinus rate is slow enough and you have a bunch of non-conducted beats, your cardiac output will decline and you may start to notice some signs of hypoperfusion, such as fatigue, lightheadedness, syncope, angina. But in general, most patients are going to be asymptomatic. Let's talk about your diagnosis next with an ECG. Obviously, highest yield thing to know here is going to be a progressive prolongation of the PR interval followed by a non-conducted P wave. So when you look at your ECG for Mobitz type 1, aka Wenckebach, you're going to see this trend of the PR interval progressively lengthening with each beat. It gets wider and wider and wider until eventually, boom, dropped beat. You'll have a P wave, but no QRS complex. And once this happens, starts all over again, PR interval longer, 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 dropped beat. This can happen in patterns, 3 P waves to every 2 QRS complexes, 4 P waves to every 3 QRS complexes. So comparing this to a first-degree block, remember a patient with a first-degree block had a prolonged PR interval, but it didn't get progressively longer. And most importantly, there was never a dropped beat. All P waves were followed by a QRS complex. So you can see the difference here. All right, so that's the typical ECG finding, pretty simple. So I have another rhyme for you with a Mobitz type 1, aka Wenckebach. The PR interval gets longer and longer and longer until it eventually drops a beat. So for Wenckebach, remember the rhyme, longer, longer, longer drop, then you have a Wenckebach. So again, longer, longer, longer drop, then you have a Wenckebach, because the PR interval gets longer and longer until it drops. Another way I've heard of remembering it is by remembering the W in Wenckebach stands for warning, because the PR interval progressively gets longer and longer and kind of warns you of the impending drop. Let's talk about treatment next. So treatment goes like this. If they're asymptomatic, they're stable. In most cases, they don't require any treatment. If they're symptomatic and most importantly, hemodynamically unstable, hemodynamic unstable meaning they're hypotensive, they have altered mental status, chest pain, etc., you're going to give them atropine. So why atropine? Well, atropine speeds up conduction through the AV node, which in a patient with an AV block with slow conduction through the AV node, that would obviously be ideal. Atropine achieves this by blocking the parasympathetic influences on the heart, specifically the effects of acetylcholine, and that's why atropine is usually used first line in these unstable patients. Now, if atropine is ineffective, you can use temporary cardiac pacing, and then finally, as a last resort option, in patients that have symptomatic bradycardia with no reversible etiology, no meds to discontinue that may be causing it, no electrolyte disturbances that can be fixed, then in those patients, they'll need a pacemaker. So quick recap of a Mobitz type 1, aka Wenckebach, second-degree AV block. This is a progressive delay in the transmission of electrical signals from the atria to the ventricles, occasionally resulting in a non-conducted impulse. Block is going to be at the level of the AV node in most cases. Etiology, remember, blocks, B-L-O-C-K-S, beta blockers, Lyme disease, ordinary, calcium channel blockers, K increase, and STEMI. Most patients will be asymptomatic. On ECG, you're looking for longer drop. Then you have a Wenckebach. Treatment, asymptomatic, just observe. Symptomatic and unstable, atropine. And finally, last line definitive option is a pacemaker. Let's talk about our Mobitz type 2 next. So what I want you to recognize with a Mobitz type 2 is this shift once we get to a Mobitz type 2 and beyond. And that shift is that once you cross the threshold of a Mobitz 2, it gets more serious. You'll notice we're not really going to see this in our young, healthy athletes anymore. The treatment is going to be more aggressive, so just kind of be aware of that. So Mobitz 2 is a disease of the cardiac conduction system leading to occasional dropped beats with a PR interval that is fixed and consistent. So you still have the non-conducted beat in a Mobitz 2, but the big difference between a Mobitz 1 and a Mobitz 2, and what you really need to focus on, is that in a Mobitz 2, the PR interval remains constant. You do not have that progressive prolongation like we saw in a Mobitz type 1 block. So that's the main difference between the two. Mobitz 1 was longer drop. Mobitz 2 is same drop. So why does a Mobitz 2 have a fixed PR with dropped beats and a Mobitz 1 had progressive prolongation with dropped beats? Well, it's due to the area of the heart where the block occurs. So a Mobitz 2 block almost always results from a block below the level of the AV node. The block is at the bundle of His in approximately 20% of cases, and in the bundle branches in the remainder. This is different than in a Mobitz type 1, as we discussed before, that almost exclusively occurs at the level of the AV node. So Mobitz type 1, the block is at the AV node. Mobitz type 2, the block is below the AV node. And because of this one small difference, your ECG findings are going to be different, your treatment options will change, and we'll go over more about that in a minute. Now, as far as etiology, there's not a lot new to know here compared to a Mobitz type 1, so I'm not going to bore you with the details. Meds, myocardial infarction, myocarditis from Lyme disease, hyperkalemia. The key difference, though, and what I really want you to remember, is that we are no longer going to see this in our young, healthy, athletic patient. A Mobitz type 2 block is rarely seen in patients without underlying heart disease. So this is no longer going to be a normal variant like we saw in the first couple of AV blocks we went over. Patient with Mobitz 2 generally has something else going on, some type of structural heart disease to get to this point, myocarditis, myocardial ischemia, fibrosis, etc. Main takeaway here for etiology and what differentiates it from a Mobitz 1 and a first-degree block is that difference. So the mnemonic we went over before still applies, just subtract the O for ordinary, as this is rare to occur in a normal ordinary patient without underlying heart disease. So remember that shift I talked about before. Once we got to a Mobitz 2, things are getting more serious at this point. Clinical manifestations next. So clinical manifestations, they can widely vary, and I don't think you need to memorize each individual symptom, but what you do need to know is that patients with the Mobitz type 2 second-degree AV block will present with some form of symptoms. It can be mild fatigue dyspnea, all the way to syncope and sudden cardiac arrest. But the key takeaway is, unlike the other two AV blocks we talked about previously, where many patients were asymptomatic, it's not really going to be the case with the Mobitz 2. They usually are going to have some degree of symptoms. Remember that shift I keep talking about. All right, let's talk about what we're going to find on our ECG in a patient with a Mobitz 2 next. So in a Mobitz 2, you're going to have PR intervals that are the same, no progressive prolongation, and they will be followed by a P wave that fails to conduct to the ventricles, so a sudden dropped beat, no QRS complex. So you're looking at your ECG, you see your P wave followed by a QRS complex as expected. Next beat, P wave, PR interval the same as the last, no prolongation, aka no warning like we saw in a Mobitz 1. Then all of a sudden, dropped beat, no QRS complex. That's the pattern to look for, unchanging PR interval that suddenly a P wave fails to conduct to the ventricles. The big difference, as you can see, between this type of second-degree heart block compared to a Mobitz type 1, as we went over before, is that there is no lengthening of the PR interval with each beat. And I keep saying that over and over, but I really want to drill that point home. So the PR interval, that's the key to differentiate between the other type of second-degree heart block. The PR, it can be prolonged, but most of the time going to be normal. But however long or short the PR interval is, it's not going to change. The length will remain the same, and the reason why it remains consistent in a Mobitz 2 and is progressively prolonged in a Mobitz 1 all pertains to the area the block is occurring, and we touched on this before, but just to give a little more info. So remember, a Mobitz 1, generally the block is at the AV node, Mobitz 2 below the AV node. Well, in a Mobitz 1 that affects the AV node, those AV nodal cells, they're pretty resilient, and even though they're facing increased resistance with each beat, taking a little longer to conduct a beat with each interval, they tough it out for a period of time and still carry that beat through until eventually they just can't take it anymore and they just collapse and drop the beat. In a Mobitz 2, though, the block is below the AV node in the His-Purkinje system. And these guys, they're all or nothing. They either give it their all and conduct a beat, or they don't do crap and they just drop it. There's no progressive lengthening of the PR. It's the same. The beat is either conducted or it's not. They don't play no games. So it's usually fairly easy to distinguish between a Mobitz 1 and a Mobitz 2 on ECG. Just look at the PR interval. If it remains constant with occasional drop beat, it's a Mobitz 2. If it progressively prolongs and leads to a drop beat, Mobitz 1. Nice and simple, unless you have a 2-to-1 block, that is, which I'll go over shortly. So how do you remember Mobitz 2 ECG finding? What's the rhyme for this one? So you remember, if some P's don't get through, then you have a Mobitz 2. If some P's don't get through, then you have a Mobitz 2. That's how you remember the ECG findings. Let's talk about treatment next. Treatment, it's a bit different compared to a Mobitz 1. So a Mobitz 2, it's a slippery, unstable beast. You can never let it out of your sight. So even in a stable patient, you're going to watch them closely and you're going to throw some transcutaneous pacing pads on to be ready in the event where things go south. You can't just send these patients home and call it a day. That's because a Mobitz 2 can frequently progress to a 3rd-degree AV block, which we'll talk about next. And eventually, even your stable patients will likely require a pacemaker unless a treatable underlying cause is found. Now, if they're unstable, hemodynamically unstable, hypotension, altered mental status, signs of shock, etc., they're going to get a beta-adrenergic agonist like dopamine, dobutamine, epinephrine, as long as there's no signs of myocardial ischemia. And in addition, these patients will often receive temporary cardiac pacing. Now, you may be asking yourself, why don't we give them atropine in a Mobitz 2? Well, I'll give you a second to think about that. Think back to where the level of the block is. So the effect of atropine, as we discussed before, it's mainly on the AV node. Remember, atropine decreases the refractory time and speeds up conduction through the AV node, and that was great in a Mobitz 1 that mainly affects the AV node. But what area of the heart is affected in a Mobitz 2? That's right, I've said this so many times. It's below the AV node, infranodal. So we don't use atropine in a Mobitz 2 block. In fact, it can actually worsen the block in some cases. So you stick to your beta-adrenergic agonists, dopamine, dobutamine, etc. Finally, unless there's a reversible cause, underlying reversible cause found, most patients with a Mobitz 2 heart block, they're going to get a pacemaker. So remember, back to that shift I keep talking about. I want you to recognize this. Up until now in a 1st-degree heart block in a Mobitz 1, if the patient was asymptomatic, they didn't need a pacemaker most of the time. But once we get to a Mobitz 2, because of how unstable this type of heart block is, everyone's getting a pacemaker unless there is some underlying treatable cause found. So just remember that when it comes to treatment, once you hit a Mobitz 2 or above, most patients are going to get a pacemaker. So a quick recap for Mobitz 2, 2nd-degree AV block. It's a disease of the cardiac conduction system leading to occasional drop beats with a constant PR interval. The block is going to be below the level of the AV node in most cases, in almost all cases. Most patients will have some form of underlying heart disease. Symptoms are variable anywhere from plain old fatigue all the way to sudden cardiac arrest. ECG shows a constant PR interval followed by one or more dropped beats. Treatment, most patients will get a pacemaker unless there is an underlying treatable condition. Avoid atropine, and that is a Mobitz 2. Now, before we move on to the last topic, which is a third-degree AV block, I want to quickly go over one other variation, which is the dreaded 2-to-1 AV block. So to understand what a 2-to-1 block is, we need to first understand something called AV conduction ratio. So with a second-degree heart block, these types of blocks, when consistent, can be named by the ratio of P waves to QRS complexes. So you look at your ECG, you count up all of the P waves and then all of the QRS complexes until the first dropped beat. And then the ratio is based on the number of each. So if there's 4 P waves, 3 QRS complexes, that's a 4-to-3 ratio. So for every 4 P waves, there was 3 QRS complexes. So an example, you're reading your ECG, there's a P wave, QRS complex, P wave, QRS complex, P wave, dropped beat, no QRS complex. This type of block would be a 3-to-2 block because there was 3 P waves and only 2 QRS complexes. So now that we understand AV conduction ratio, let's talk about a 2-to-1 block. So a 2-to-1 block means that every other P wave is blocked. Every other P wave is not followed by a QRS complex. One conduction, then no conduction, one conduction, and no conduction. So the reason this is so important and so upsetting when you see it on ECG is if you have a 2-to-1 second-degree block, there's no way to assess for PR lengthening. You can't determine if this is a Mobitz type 1 or a Mobitz 2 because it never goes long enough for you to see if there's that progressive PR lengthening to say, okay, this is a Mobitz type 1. It just keeps dropping the beat right away. So this is really the only instance where you can't determine a Mobitz 1 from a Mobitz 2 on ECG. There's strategies to help with this in real life. You can obtain a long rhythm strip, a previous ECG. There's certain vagal maneuvers like a carotid sinus massage that you'll only do in specific patients because that can be dangerous. Also, if the PR interval is really long, over 300 milliseconds, or the QRS complex is narrow, that's more consistent with the Mobitz type 1. These aren't things I think you need to memorize, and I only mention this type of block not because I think you're going to get an exam question, because that would just be evil, but I just want you to be ready when you're out there practicing or in clinicals to be familiar with this, as it's something you may see. All right, so let's move on to the last topic, and that is a third-degree AV block, which is a defect in the cardiac conduction system in which all atrial impulses fail to reach the ventricles, leading to complete dissociation of the atria and ventricles. So you can see why this one is so serious. Before, we either had delays in the impulse or occasional drop beats, but in this case, it's no longer an occasional occurrence. There is a complete persistent loss of conduction from the atria to the ventricles. No atrial impulses are reaching the ventricles, which is why this is sometimes known as a complete heart block, because nothing's getting through anymore. As far as your etiologies, nothing really new here. The main ones are going to be the same as the other AV blocks we already went over. Your AV nodal blocking meds, myocardial infarction, myocarditis from Lyme disease, hyperkalemia. This list, of course, doesn't include every etiology, but these are the main ones to focus on. Clinical manifestations, just as in a Mobitz 2, clinical manifestations can widely vary depending on a number of factors, anywhere from fatigue, dyspnea, and chest pain to syncope and sudden cardiac arrest. Main takeaway, nearly all patients with a third-degree block will present with some degree of symptoms. It's uncommon for these patients to be asymptomatic. Diagnosis, let's talk about your ECG findings next. What's a third-degree block look like on an ECG? So I'm going to go over a few different things to look out for on an ECG in a third-degree block, but this first one, this is by far the most important. There will be a complete dissociation between the P waves and QRS complexes. This means that the atria and ventricles are beating independent of each other. In a normal ECG, in a normal healthy patient, we expect to see a P wave, then a QRS complex, a P wave, QRS complex, P wave, QRS complex, etc. That's not happening anymore. The atria and the ventricles, they no longer have a line of communication. They're no longer on speaking terms. And because of this, you'll see P waves marching right on through the QRS complexes. And that's the best way to think of it. They have no perception of where the QRS complex is. So they'll be right next to a QRS complex. They're going to be way far from a QRS complex. They'll be in the middle of a T wave. It's just everywhere. There's no pattern to it anymore like we're used to. They're just marching straight through, which is helpful to identify this type of AV block. And if we're thinking on the terms of a PR interval, or at least the appearance of one, because it's not really the case here anymore, this is going to be completely variable. So it's going to be prolonged, shortened, or even absent. So there's really no pattern to it anymore at all. And you might ask yourself, since we have a complete block, the atria can't get through to the ventricles to send a signal to tell them to contract, how do we still even have QRS complexes? How are the ventricles still contracting if they're not getting that message? So the heart actually has a backup system. So there's a pacemaker in the ventricles as well as other places, but they're usually suppressed by the normal and faster supraventricular rhythm. But when that supraventricular rhythm is no longer sensed because of this block, the backup system kicks in and the lower conduction system of the heart takes over and generates its own electrical impulses. And these are called escape rhythms. And while these escape rhythms can be slower and at times unreliable, they're essentially the only thing keeping the patient alive and preventing a sudden cardiac arrest. All right, so that's the first thing and most important thing to be aware of on ECG, that AV dissociation, no relationship between P waves and QRS complexes. Next thing to look out for in an ECG is that the P wave is going to be greater than the QRS rate. So the P wave is going to be greater than the QRS rate. So on ECG, you'll notice there's more P waves than QRS complexes. So why is that? So the atria is going to maintain its regular rhythm and continue to generate electrical impulses at the normal atrial rate, which is generally between 60 to 100 beats per minute. In contrast, the ventricles are now generating these escape rhythms, as we discussed before, and these escape rhythms have a much slower rate. How slow depends on the level of the block, but in general, junctional escape rhythms tend to have a rate between 40 to 60 beats per minute, and ventricular escape rhythms typically have rates of 40 beats per minute or less. So remember, on ECG, in a complete heart block, you'll see more P waves than QRS complexes. And last little note, be aware that in a third-degree block, you'll usually have regular P to P and regular R to R intervals. Despite the atria and ventricles no longer communicating with each other and working in tandem, the rhythms still remain consistent. They still know what they're supposed to do. So this means that each P wave will still occur at the same interval. Each QRS complex will also pop up at the same interval. They'll just have nothing to do with one another, but they'll still show up as expected with normal intervals. And this regularity can sometimes help identify a hidden P wave that may be hiding out inside of a T wave or maybe hidden inside of a QRS complex. You can measure them out and see where a P wave might be hiding. So third degree AV block, remember, P waves and QRS complexes are going to be independent of each other. They're doing their own thing, no longer on speaking terms. Remember, the P wave rate is going to be greater than the QRS rate. And finally, remember to look for a regular P to P and regular R to R interval. Most important one to remember, though, is that AV dissociation. The atria and ventricles are beating independent of each other. So how do you remember this for the exam? You remember the rhyme. If the Q's and P's don't agree, then you have a third degree. If the Q's and P's don't agree, then you have a third degree. This will help you remember the AV dissociation, which is the most important finding on an ECG for a third degree block. Then to wrap this up, let's finish it up with treatment. So hemodynamically stable patients do not need immediate treatment with atropine or temporary cardiac pacing, but you need to be ready for these patients to crash at any point. As I discussed before, those escape rhythms that are keeping these patients alive, they're unreliable, they're unstable. So you have to have those transcutaneous pacing pads in place for the event these patients start to crash, which can happen quickly. In addition, you want to be actively looking for and treating any reversible causes. Now, if they're unstable, hemodynamically unstable patients are going to be treated urgently with atropine, your beta adrenergic agonist we discussed before, dopamine, etc., and or temporary cardiac pacing. You usually start with atropine. If that's ineffective, you work your way down the line to the other treatment options, temporary cardiac pacing, etc. Once you stabilize them, it's back to the hunt again. You're looking for any underlying cause that can be treated to reverse the block, because ultimately any patient that has a third degree block where you cannot identify a reversible etiology, they're going to get a pacemaker. Most patients with a third degree block are going to get a pacemaker unless you can find some underlying treatable etiology. So that's your treatment for a third-degree block. So a quick recap of a third-degree AV block. This is a defect in the cardiac conduction system where a complete block leads to zero atrial impulses reaching the ventricles. You're going to have a complete dissociation of the atria and ventricles. Causes are similar to the other types of heart blocks, meds, MI, myocarditis due to Lyme disease. Symptoms are going to widely vary, anywhere from fatigue and dyspnea to sudden cardiac arrest. Diagnosed with ECG, which will display complete dissociation between the P waves and QRS complexes. Definitive treatment will be with a pacemaker unless a treatable underlying cause is found. And that is your third-degree heart block. Before we move on to a few questions to test your knowledge, I wanted to do a quick review of the 4 types of heart blocks we went over, highlighting just the highest yield info from each. So starting with your first-degree AV block, there's not a lot to know here, but of course remember your PR interval over 200 milliseconds, more than one big box, that's the key. All impulses are getting through, which is what will separate it from other AV blocks. No frills, nothing fancy, nice and simple, just a PR interval over 200 milliseconds. Remember, this is often a normal variant. And then, of course, remember the rhyme. If the R is far from the P, then you have a first degree to remember that prolonged PR interval. Second degree Mobitz type 1 Wenckebach. Remember, this block usually occurs at the AV node. That's going to be the most common. And that's why atropine is used in a Mobitz 1 and often not used in a Mobitz 2, which usually occurs below the AV node. Just like in first degree block, remember this can be a normal variant. And then the highest yield piece of info, remember your ECG findings. The PR interval will progressively prolong with each beat until eventually a P wave will fail to conduct to the ventricles, leading to a dropped beat. And you, of course, remember this by remembering longer drop, then you have a Wenckebach. Let's talk about second degree Mobitz type 2 next. Remember, the infranodal will be most common. This block almost always results from conduction system disease below the level of the AV node. So at the bundle of His or at the bundle branches, remember, because of this, atropine is going to be avoided. And then on ECG, remember, you're looking for PR intervals that are generally the same, no progressive prolongation like we saw in a Mobitz 1, and they will be followed by one or more P waves that fail to conduct to the ventricles, so a sudden drop beat, no QRS complex. Remember, if some Ps don't get through, then you have a Mobitz 2. If some Ps don't get through, then you have a Mobitz 2. And then remember, once you hit the level of Mobitz 2, we're getting a lot more generous with our pacemakers. At this level and higher, everyone's getting a pacemaker unless a treatable underlying cause is found. This is different than Mobitz 1 and first degree block, as we talked about before, where your asymptomatic patients could just be monitored and sent home. So remember that shift in treatment at this level. Finally, third degree block. Remember, you have to remember your ECG to look for the P waves to be marching right on through the QRS complexes. They will be completely out of rhythm, complete AV dissociation. That's the key to remember. If your Qs and Ps don't agree, then you have a third degree. And then just as in a Mobitz 2, most patients will get a pacemaker unless there is an underlying treatable cause. All right, let's wrap it up with 5 quick questions. Question 1. Mr. Jacobs, a 63-year-old male, presents at the office complaining of episodes of dizziness and intermittent syncope. Mr. Jacobs has no significant medical history, is not currently on any prescription medication, and his family history is negative for any cardiac conditions. The following ECG was obtained. Laboratory tests, including a CBC, CMP, cardiac enzymes, are all within normal limits. Imaging studies reveal no abnormalities. Considering the likely diagnosis, what would be the most appropriate definitive treatment for Mr. Jacobs' condition? And then also you should ask yourself, what type of block is this? So what is the answer? The answer is going to be pacemaker. And then let's start with, what does this patient have? So he has a Mobitz 2 second degree heart block. This is evident by the consistent unchanging PR intervals that we can see here, followed by a sudden failure of conduction. Most importantly, you'll notice that there is no progressive prolongation, which helps rule out a Mobitz 1. Next, he has no underlying treatable conditions, at least that are mentioned in the vignette. He's not taking any meds that can be to blame. Labs and imaging studies are normal. So we have no underlying treatable condition that could be to blame for the AV block. And as we discussed before, a patient with a Mobitz 2 with no underlying treatable etiology, they need a pacemaker, and that's why that's the answer for this question. Question 2, a 57-year-old female with a history of hypertension is brought to the emergency department by ambulance. Patient is experiencing chest pain along with altered mental status. On examination, she appears pale and diaphoretic. Blood pressure is 80/50 millimeters of mercury. An ECG is obtained, which is displayed below. Given the likely diagnosis, which medication should be promptly started in this patient? So what should we start in this patient? Which medication? That's going to be atropine. So we have a patient with a Mobitz 1 2nd-degree AV block. This is evident as on the ECG. We can see that progressive lengthening of the PR interval with occasional non-conductive P waves. This patient is clearly hemodynamically unstable. She has altered mental status, chest pain, hypotension. So we know we need to act fast, and the first-line treatment for an unstable Mobitz 1 is going to be atropine. If the patient remains unstable, transcutaneous pacing is another option, but you start with atropine, which speeds up conduction through the AV node. And of course, be careful, because if I change one small detail, and this patient instead had a Mobitz 2, we know we would avoid atropine, because we know Mobitz 2 is generally caused by a block below the AV node. Question 3. Ms. Smith, a 60-year-old female, presents to the office for her annual physical exam. She has a history of hypertension, hyperlipidemia, osteoarthritis, and is currently taking verapamil, atorvastatin, and naproxen. Additionally, she recently completed a course of amoxicillin for a sinus infection. ECG is obtained, which reveals a first-degree heart block characterized by a prolonged PR interval. What intervention could be pursued to potentially alleviate the first-degree block seen in this patient? So that is going to be to discontinue verapamil. So all of the other stuff in this vignette, including the sinus infection, the antibiotic, they're just all distractors. It's all about the verapamil. So remember, there's a lot of causes for AV blocks, and while you don't need to memorize them all, you should be really familiar with your medications. And remember, any medication that can impair or slow nodal conduction can lead to an AV block. Digoxin, beta blockers, and in the case of this patient, non-dihydropyridine calcium channel blockers. I've definitely had trouble saying that throughout this video, specifically verapamil. So remember, it's those agents specifically, those non-dihydropyridines are going to be verapamil, diltiazem. Those are the ones with the big issues with AV blocks, because these type of calcium channel blockers, they slow cardiac contractility and conduction compared to your dihydropyridines like amlodipine, nifedipine, etc., which generally don't have this effect and are predominantly vasodilators. So if you need a way to remember those non-dihydropyridine agents, verapamil, diltiazem, what I used to remember is that these two both start with the letters D and V. Then it helped me remember that they decrease velocity, remember, because they affect the conduction and the contractility. They decrease velocity, diltiazem, verapamil, D and V. So that helped me remember those two specifically if you ever need to remember those for an exam question. All right, moving on to question 4. Which type of AV block is found in the ECG below? Which type of AV block is found in the ECG below? So I'll give you a second to take a look at that and figure out what it is. So that is going to be a 3rd-degree AV block. So this is a clear example of a 3rd-degree AV block. We can see the P waves marked off by the red lines here. They're marching right on through the QRS complexes. There's absolutely no relationship between the two. They're right next to the QRS complex. They're far from it. They're mixed into T waves. There's just no pattern there. So we can also see there's more P waves than QRS complexes, indicating a faster atrial rate than ventricular, as expected in a 3rd-degree heart block. So that one was pretty easy, I hope. And then question 5, a 45-year-old female presents to the emergency room with complaints of fatigue, arthralgias, and a rash. She's employed as a park ranger and spends most of the day outdoors. She has a history of type 1 diabetes, hypertension, and is currently taking Lantus, Novolog, and lisinopril. An ECG is obtained which reveals a Mobitz 1 2nd-degree AV block. Considering the patient's medical history and symptoms, which of the following diagnostic tests would be most appropriate to help determine the underlying cause of the AV block? Choice A, chest x-ray. Choice B, Lyme disease serology. Choice C, cardiac catheterization. D, hemoglobin A1C. Or E, toxicology screening. So look at the patient's symptoms, the history, which one is going to help us determine the underlying etiology. That is going to be B, Lyme disease serology. So this patient has fatigue, arthralgias, a rash. She works outdoors as a park ranger and has an AV block. Lyme disease should definitely be high on your list of differentials, as it appears this patient has early disseminated disease and she's developing Lyme carditis, which is leading to an AV block. So Lyme serology would be an important diagnostic test to order in this patient, as this is likely the underlying etiology of the AV block. All right, so thank you so much for watching the video. I really hope it helps. Please let me know in the comments if it is. And if you have any suggestions for future videos, I would love to hear it. Thank you as always, and good luck in school.